Welcome to Health Watch In-Depth, presented by UMass Memorial Healthcare. I'm your host, Andy Madison. We're talking about what's new in healthcare. We're joined by Dr. Nancy Byatt, who's here to talk to us about treating depression in pregnant women and postpartum women. Now, can you just start off by talking about what are the new guidelines for screening pregnant and postpartum women for depression?
So the U.S. Preventative Task Force recently came out with some guidelines in which they recommend screening for pregnant and postpartum women. And in that recommendation, they also recommend that if you screen, it needs to be done in conjunction with interventions to make sure that women get into treatment.
Now, why is the U.S. Preventive Services Task Force taking this action?
It's well established that if a pregnant woman has depression or anxiety, that it can increase the risk of the woman having poor birth outcomes, getting poor prenatal care, and it can also, she can have the baby earlier, and also it can impact the woman's ability to bond with the baby in the postpartum period. And then also later on, it can even affect mom and baby's interaction later on and increase the risk of the child later on having their own anxiety or disruptive disorders. So in summary, it's really well established that depression during pregnancy and the postpartum period has a negative impact on mom, on the baby, and potentially on the whole family. And so my understanding is they came out with these recommendations because I think the field's recognizing that, the medical field's recognizing that this is a really vulnerable time period for women and that it's really important to be screening them, assessing them, and treating women during this time period.
How will this help doctors and patients?
My hope is that this will compel insurance companies to be reimbursing for screening, and that also it will compel states and insurance companies and ACOs to be able to create programs whereby if a provider screens a patient, that they fund interventions where there'll be a system in place to help women get care. Because screening alone, as the recommendations say, screening really has to be done in conjunction with intervention to make sure that women can actually get into treatment.
Pregnancy seems like such a happy time, and especially when the children are born, it seems like a happy time as well. What is it that triggers the depression during the pregnancy and in postpartum women?
The postpartum period, having a baby is not necessarily a happy time. I think that's a complete myth that really needs to be dispelled, because really having a baby is incredibly challenging. It's one of the most extraordinary challenges I think that any woman can go through in her life. And often around that time, even if someone doesn't have depression, it's very challenging. And it can put strain on a relationship, it can put strain on mothers in general and on their family relationships. And so what we think is happening when women get depression during this time period, that's really due to multiple causes. So there are hormonal fluctuations that occur that can increase the risk and that are contributing. The other thing that can contribute is that having the baby itself is hard and the changes in the family that occur. And the other piece is that sometimes women have a biological component. So if they have a family history of depression or they have their own history of depression, that can also increase their risk of getting depression during this time period.
Is depression present during the pregnancy or only after the baby is born?
Typically, of women who get postpartum depression, quite a few of them actually develop depression before the baby's born. There was a very large study in which they screened 10,000 women for depression. And of the women who developed depression, which was about 15% of the women of that 10,000, which is typically the rate of depression among this population, of those women, a third of the women who had postpartum depression entered pregnancy depressed. Another third became depressed during pregnancy, and about 40% became depressed in the postpartum period. So what that study tells us is that of women with postpartum depression, 2/3 of them actually develop the depression before the baby's born. So it's incredibly important, and the recommendations do speak to this, that providers screen during pregnancy and that they start addressing it, and they even talk about this preconception before the baby's conceived, so that the goal would be that women can actually enter the postpartum period and they can even prevent postpartum depression by treating it before the woman delivers the baby.
When a woman is pregnant, what are some signs to look for that may indicate depression?
General symptoms of depression, what can often occur, is that when people are depressed, sometimes changes the way people feel about themselves. So for example, somebody that was previously confident may start to feel bad about themselves. They may start to feel guilty for things they have or haven't done. They may feel worthless. It also affects the way they feel physically, so people can often lack energy. They may not be motivated to do things, or they may be able to do them, but it may be a struggle. And the other thing that often happens is that people may have trouble sleeping, or they may sleep too much, or they may sleep too little. It can also affect their appetite, so either increased or decreased appetite. And then also, people sometimes don't enjoy things as much as usual. So they may go to activities, but just not get the same type of enjoyment they had before they became depressed. And then the other piece that it can affect is sometimes people become depressed enough that they have thoughts that they don't want to live. And people may feel bad enough about themselves or depressed enough that they feel that life isn't worth living. And also, one of the major symptoms of depression is having a depressed mood. And when typically it's depression, it's typically they experience depressed mood for most of the day on most days.
How about postpartum?
So postpartum, those symptoms are very similar that occur in the postpartum period. One thing we do often see with postpartum women is that it's often, sometimes those thoughts of them feeling bad about themselves are related to the baby. So that's something that we see that's a little bit different in postpartum than in pregnancy. So for example, women may be concerned that maybe they're not a good mother, or they may feel, for example, I've worked with patients that have told me, I'm going to give the baby to my mom and have my mom give the baby a bottle because the baby's better off with my mom. And someone who previously might not have felt like that. And then the other thing that women often experience is sometimes they don't bond with the baby. This could be someone who had a planned pregnancy, who was planning on having a baby, who was very excited. But then once the baby comes, they may feel that they don't fall in love with the baby or don't bond with the baby. And that doesn't always happen, but sometimes that's a sign.
How long of a period is postpartum?
So when we talk about depression during this time period, the term perinatal depression refers to depression that occurs in pregnancy or in the first year of postpartum. So postpartum depression typically is referring to the year after the mom has the baby.
Is there a period when the woman is less likely to experience depression?
So depression can really occur for any woman at any time period in her life. Postpartum depression most often occurs within the first 3 months postpartum, and then the risk goes down a little bit between 3 and 6 months, and then again between 6 and 12 months. Even though after a year, people can still develop depression, because any one of us are at risk of depression at any time. But if you're thinking about the postpartum period, the risk does go down as the year progresses.
Tell me about the MACAP for Moms program, and if you could just start off by explaining the MACAP acronym.
Sure. So MACAP for Moms, the MACAP part stands for the Massachusetts Child Psychiatry Access Project for Moms. And so what MACAP for Moms is it's a program. I'm the medical director of that program. And what we do, our goal is to build the capacity of frontline providers who work with pregnant and postpartum women to help them address depression. And the reason we have this program is 1 in 7 women experience depression. Most women, even if they're screened positive for depression, don't get into treatment. Studies consistently show that less than a quarter of women get to initial appointment with a mental health provider. So screening by itself really isn't enough, as the task force notes in their recommendations. And so what we do is our goal is to help providers manage those patients. And we do that in 3 ways. We go out to practices, and I should add, we serve any provider working with pregnant and postpartum women. So obstetric providers, primary care providers, psychiatrists, and pediatrician screening at well child visits, and really any provider or family practitioners who practice obstetrics. So if a provider is working with a patient and they have a question, they can call and they can speak with a psychiatrist who will answer their questions. And really our goal is to help guide them and provide consultation to help them manage their patients. So that's one prong of a program where we provide consultation to psychiatrists. We can also see patients in the office and evaluate them and provide recommendations back to the provider. The other thing we do is care coordination. So if we're on the phone with a provider because they call us with a question and the provider's having difficulty finding a therapist for the patient, we ask one of our care coordinators to follow up with the patient and actually help the patient get an appointment with a therapist. Or we can also give resources to the provider. And then the third prong we do is training. So our goal is to go out to all the practices in the state and train them in what are the signs and symptoms of depression? What do you do when a patient screens positive? How do you screen for depression? And what are the steps that you take when a patient screens positive? And so our goal is really to build the capacity of these frontline providers to address depression and thereby increase access to care by helping them manage them. Because the reality is there's not ever be enough psychiatrists to see all these patients, and so we want to help our colleagues do that by providing consultation to them.
How is MACAP for Moms making a difference here in Massachusetts?
So we're very excited about MACAP for Moms and the feedback we get from providers. So I was actually at a meeting last night, and the provider said that he had a patient, he didn't know what to do, he called us. The patient wasn't able to connect with care prior to this. They called our line, they talked to a psychiatrist. Our care coordinator linked her, and the patient got care. And this is a patient who had been really struggling to get care and was also very hesitant to get care. And this provider was telling us that he really did not know what to do with his depressed patients before our program, and he really felt that now we have a lifeline. And we hear that a lot from providers. And so I think the way we're having an impact is we're helping these providers in the community address depression. And so far, we've served over 1,200 women so far. Our program's been open for 18 months. We've served over 1,200 women throughout the state, and we've also enrolled over just about 50% of the practices in the state, and trained almost 50% of them as well. So, and actually other states in the country are also looking at replicating our program, and a couple already have. So we're very excited about the impact that we're having, because it really seems like by helping these frontline providers help patients, that we're helping them get into care. And we're also hopefully helping to, our goal is really to have depression care be a part of obstetric care, just like diabetes. A woman would never not be screened for diabetes in pregnancy. It's a routine part of obstetric care. And our goal is to help obstetric providers to be able to provide depression care in that same way. So it's a routine part of care, and that women get the care that they need.
How important is family in helping with depression in pregnant and postpartum women?
I think the really important thing is that all of us in a family, whether the parents, the partner of the mom, and everybody, are letting the mom know that having a baby is really challenging. It's an extraordinary challenge, and that having her get support and help is the best thing she can do for herself and her baby. And the more that providers and also families can continue to send that message to women, and that women will hopefully absorb that, I think that can make a huge difference. Because a lot of what happens is that women often think, well, I've had a baby, and so I should focus on the baby, and that will be best for the baby. And what we really know as clinicians, and we know this from studies, is that the best thing a mom can do for herself and her baby is get the help that she needs.
So if someone needs help, or a family member needs help, what should they do?
So what we recommend is they can talk to their provider, to their medical provider, and that could be an OB, it could be a psychiatrist, or it could be their primary care physician. And then they can let them know that their provider can call us and can ask us questions. And actually, they can also go on our website. It's www.mcpap4moms.org. And on our website, we have a lot of educational material for patients. They can actually also go in and put in their zip code and search for a support group. And we also have information about how to talk to your provider about depression. And the provider can call us, so they have a resource, and their provider can also call us to help them link with therapy.
Dr. Nancy Byatt, thank you very much for your time. We're going to take a break, but we'll be back with more Health Watch in Depth presented by UMass Memorial Healthcare right after this.
When it comes to healthcare, one phone number is all you need to remember: 855-UMass-MD. 855-UMass-MD connects you to our network of more than 1,600 great doctors with expertise in every specialty for adults, kids, and babies. More doctors, more expertise, more locations. Wherever you are, we are there. UMass Memorial Healthcare. 855-UMass-MD.
Welcome back. We're joined by Dr. Carolynn DeBenedectis to talk about new mammography screening technology. Dr. Benedectis, now a recent study showed that 3D mammography is actually more effective in finding breast cancer. Have you found that to be true?
Yes, so the study you're referring to was recently published in Radiology, which is our biggest journal in radiology, and it showed that digital breast tomosynthesis, which is the 3D mammography that everyone talks about, increased the detection rate of breast cancer, invasive breast cancer, by almost 54%. And that included women from ages 40 to ages 69 in that study. So yes, in our personal practice, we are definitely seeing it anecdotally. We have not done any statistical analysis, but I can tell you we are seeing an increased detection rate of invasive cancers when we do use tomosynthesis, as well as we're seeing a significant decrease in the rate of people being recalled from screening on those patients that get digital breast tomosynthesis, because it helps us really read the mammogram better. And that's kind of one of the controversies with screening mammography, is people are getting called back for falsely positive findings. But we're seeing that decrease when digital breast tomosynthesis or 3D mammography is used.
So what are the benefits of using 3D mammography?
Well, there are lots of benefits to using 3D mammography. When you use it on screening mammography, it decreases callback rates. And callback rates can cause callbacks from screening where they say, oh, oops, there's an abnormality, you need to come back and we need to work it up more, causes a lot of anxiety because despite the fact that probably 2% of people that call back actually have cancer, everyone who gets called back, which is about 10 to 15% of patients, think they have cancer, and it causes quite a great deal of anxiety. So one of the biggest benefits we see to 3D mammography is decreasing that callback rate, thus in turn, which would decrease patient anxiety. Another benefit to digital breast tomosynthesis is its increased sensitivity for the detection of cancers. As I've said previously, the detection rate of invasive breast cancers in patients who get digital breast tomosynthesis or 3D mammography is greater, up to over 50% more invasive breast cancers are detected using digital breast tomosynthesis or 3D mammography. However, the biggest benefit is shown in those patients who have dense or heterogeneously dense breasts, which are historically difficult mammograms to read because there's lots of overlapping tissue, the tissue's white, the masses are white, it's kind of difficult to differentiate them. This breast 3D mammogram is shedding a whole new light on this and making those mammograms much easier to read. And because it's making these mammograms easier to read in dense breasts and more sensitive for the detection of cancers in dense breasts, patients that historically mammography hasn't been that useful in, like patients age 40 to 50 because they're premenopausal and their breasts tend to be denser, now 3D mammography helps these women so that mammography is more efficacious and more sensitive in this population specifically.
Is the process of using 3D mammography much different than the traditional screening process?
No, not really. So there's a small difference, but most patients could have a 3D mammogram and not even know it. Essentially, we take 4 views total, 4 pictures total, 2 of each breast. Each breast is taken in 2 different projections. And what happens is we put the breast in compression in one projection, we take the 2D mammogram and then immediately take the 3D mammogram. So it only extends that mammogram view by a few seconds. So if nobody really told you you were having it done, you might not notice unless you notice the camera moving, because the camera moves for 3D mammography, unlike 2D mammography. The one little bit of difference is there is an increase in the amount of radiation given. We're taking extra pictures. Anytime you take extra pictures, it's more radiation. Now, if you have a screening mammogram that's 2D and you find an abnormality, you will be called back anyway to get extra pictures, which will be extra radiation. Digital breast tomosynthesis, if you get it, most likely you won't need, sometimes you still do need additional images, but most likely you won't need additional images to evaluate the abnormality, or it might clear up an abnormality so you won't even know there was an abnormality because it might have just been overlapping tissue. Now, 3D mammography does increase the radiation dose by 2-fold currently. And that's a high estimate. It's a little lower than that probably, but that's the worst case scenario estimate. However, what they're working on right now is to be able to just take the 3D mammogram and then kind of reconstruct a 2D mammogram from that. When that technology becomes wider spread and more used and FDA approved, then you're going to be able to decrease the radiation dose of tomosynthesis down to about what a regular 2D mammogram is.
Are there barriers that prevent patients from receiving a 3D mammography?
Yes, there are barriers. So one is access to a facility with 3D mammography. Now, luckily for those patients here in Worcester, they don't have that problem because we provide 3D mammography at our University campus on Lake Avenue, as well as our Memorial campus on Belmont Street, as well as at our Southborough office. So we have plenty of sites here that do offer 3D mammography. But there are people that aren't as lucky in other parts of the country, other parts of the state where they don't have access to a screening site with 3D mammography. Secondly, insurance coverage is becoming an issue. We do our best to work with the insurance companies to hopefully get the patients reimbursed as much as possible, if not completely, for their tomosynthesis, but insurance coverage is becoming an issue. And patients don't want to have to pay out of pocket despite the fact that it is a better technology.
What is your recommendation for when a woman should receive her first mammography? 40, 50? So
there's a lot of recommendations floating around, and in the last few months specifically, we've heard of at least 2 different recommendations that have come out. But I want to stress, starting at the beginning of this conversation, the American College of Radiology, the Society of Breast Imaging, all recommend annual mammography beginning at age 40. And that is the Radiology Society's perspective on this, and we feel it saves lives, and we have data and research to back that up. The United States Preventative Services Task Force has recommended you start mammography at 50 and that it be every other year. The American Cancer Society, who up until a few months ago also said 40 and annually for mammography, has changed it to 45 and annually. However, they do suggest that you talk to your doctor and make sure 45 is the right choice for you and that that's not the right choice for everyone. As I think with everything in medicine, it all needs to be a discussion with your primary care doctor or your doctor who deals with your breast health. The American College of Radiology and Society of Breast Imaging, as I said, as well as radiologists, we think that 40 and annually is the best way to go because there's been data that shows that up to 25% decrease in mortality from receiving annual screening mammography starting at age 40. But you need to consult with your physician, know what's right for you. Not every woman's the same risk. There are some women who are much higher risk and might even start some form of screening, if not mammography, earlier because they have a family history of young breast cancer. So every patient is different, and you need to consult with your physician, remembering the American College of Radiology and Society of Breast Imaging recommendations to start at 40.
Other than 3D mammography, what other latest technologies are improving outcomes for patients with breast cancer?
So MRI has been around for a little while, not anywhere near as long as mammography, but breast MRI is also improving screening for patients. This is particularly good in that population I just kind of touched upon. Those women who have mothers or sisters that got breast cancer very young, like in their late 30s, 30 years old in general, after 30, between 30 and 50 years old, or premenopausal breast cancer. Those patients, we really don't want to expose their breast to radiation under the age of 40 if we don't have to. But if their family members were getting cancer under the age of 40 or around 40, we want to start screening them ahead of the age that their family member got breast cancer. One great way to do that is to screen them with MRI because there's no radiation. Now, MRI is not a perfect screening tool because it doesn't detect sometimes ductal carcinoma in situ, which is the earliest form of breast cancer, which is exactly when we want to catch breast cancer, and mammography is much more sensitive for that. But in young patients who are at high risk, those patients are more likely to present with an invasive cancer, which might be detected on MRI. So we have younger patients doing the MRIs. And then in older patients who are also at a high risk, we have them alternating every 6 months with mammography, which exposes you to radiation, and then MRI. So that way you're being imaged every 6 months, so we have a higher likelihood of catching these interval cancers, which are cancers that occur between mammograms in the highest risk patients, but we're not exposing you to radiation every 6 months, but we're still doing the 2D mammography or 3D mammography, which will detect the DCIS or the calcifications, but we're also doing the MRI to keep track of the breast in between. So that's been around, and that's currently being used quite frequently for screening. We are also looking at screening breast ultrasound is something that there's been a lot of talk at recent breast conferences, and it shows a lot of promise in dense breasts because ultrasound is more sensitive for the detection of breast cancer than mammography in dense breasts. However, there has not been a really good head-to-head study to see if 3D mammography or screening ultrasound is better, so the jury's still a little out on that. But we are looking at that. The problem with screening breast ultrasound, it's operator dependent. Depending on who's doing it, the sensitivity and efficacy of it is kind of variable. There is something called automated breast ultrasound, or ABUS, and that's another possibility that's starting to gain popularity because it's automated. It takes away that variable factor. And some other things are breast CT, which we at UMass are lucky enough to have one investigational breast CT. It's not being used for screening, but for research right now, hopefully with the hopes of finding some positive results. And then also contrast-enhanced mammography, again, a research technique that is being looked at to maybe help.
So when a patient is diagnosed with breast cancer, what are the next steps?
Initially, the way it works from the mammographer's point of view is most patients will have a screening mammogram. If they have a screening mammogram and an abnormality is detected, they'll be called back for additional views. They'll usually have additional views or just an ultrasound depending on what's needed. After that, they'll undergo usually a percutaneous biopsy under radiology guidance. The radiologist will perform that. then they'll get the results from their provider. Once the provider gives them a result of cancer, if it is cancer, they'll then meet with a team of physicians who will take care of them. At UMass Memorial at the Comprehensive Breast Center, we have a team meeting once a week where newly diagnosed breast cancer patients come for one visit and rotate through all the specialists they need to see, such as a breast surgeon, a breast oncologist, a radiation oncologist, a psychologist, a genetic counselor, as well as a few other specialties depending on the patient's needs. So they're able to, in one stop, get all that initial visit done at our Comprehensive Breast Center. So those are mainly the initial steps, and then from there, the appropriate treatment will be discussed by the all those physicians I talked about, as well as they'll also conference with the radiologist and pathologist as well, even though you might not meet with them that day. And then they'll come up with a plan, and from there you'll either start by having surgery in some patients, or other patients might start with chemotherapy followed by surgery and radiation therapy later, depending on the specifics of their own diagnosis.
What are some preventative measures that can be taken in fighting breast cancer?
Maintaining your ideal body weight is one really good way to prevent breast cancer. Extra fat produces estrogens. Increased estrogens increase your risk for breast cancer. So maintaining an ideal body weight is a good way. Decreasing or limiting your alcohol content to no more than 1 drink a day, 1 alcoholic beverage a day, because it's been shown that alcohol increases your risk of breast cancer. Knowing your family history. If you are high risk, being screened regularly and seeing a high-risk clinic like the one we have at UMass is a really great way to help prevent breast cancer, or at least detect it early if you can't prevent it altogether. And then screening mammography. Of course, if you're going to get breast cancer, you'll still get it, but at least it can be caught early, which is helpful. Self-exams, there's some controversy about those, but seeing a doctor regularly, performing self-exams when appropriate, all of those things are great things to do to help either find it earlier or prevent it.
How important is it to get screened?
One study has shown that in the 15% of the population that does not get annual screening mammography, they account for 72% of deaths from breast cancer. Another study showed that patients who present with a palpable lump, in other words, they feel it on clinical exam versus finding it on screening, account for 80% of deaths from breast cancer. So even though mammography doesn't prevent breast cancer, the earlier it's diagnosed, the more likely you are of not dying from it, and also the amount of treatment that you may need is less. For example, if it's detected earlier, you might just need a lumpectomy, which is just taking the cancer out and leaving the rest of the breast, versus if it's detected later, you may need a mastectomy. If it's detected early, you most likely won't need chemotherapy, whereas if it's detected later, you will. And also, a lot of the argument is that, well, our treatment is just better. That's why women are doing better. And it is true, women are doing better, living longer with breast cancer, and the mortality has decreased. But people are saying it's not because of screening, it's because of the improved treatment. Well, men don't get screening for breast cancer, but men get breast cancer. Men have the exact same options for treatment, these amazing options, which are unbelievable, and the treatments that have been developed are wonderful. But mortality for male breast cancer has not changed. It's still very high, and it's much higher than female breast cancer. And the only difference between the two populations is screening versus non-screening. So I think that's a really important thing to think about when thinking of the importance of screening.
Some people are concerned about radiation. What would you tell them?
The most conservative estimate from getting a radiation-induced malignancy from mammography that would be fatal, the most conservative answer, which means it's probably not even this low, is 1 in 10,000 patients. The risk of getting breast cancer is 1 in 200. So you're way more likely to be diagnosed with breast cancer, and the actual statistic of getting a fatal breast cancer is 1 in 200. Getting breast cancer at all is 1 in 8. So the 1 in 8 chance of getting breast cancer, 1 in 200 chance of dying from breast cancer is a lot greater than the conservative estimate of 1 in 10,000 risk of getting a radiation-induced malignancy. So the benefits clearly outweigh the risks in this case.
Dr. DeBenedectis, thank you very much for joining us. We're going to take another break. We'll be back with more Health Watch In Depth presented by UMass Memorial Healthcare right after this.
When it comes to healthcare, one phone number is all you need to remember: 855-UMass-MD. 855 UMass MD connects you to our network of more than 1,600 great doctors with expertise in every specialty for adults, kids, and babies. More doctors, more expertise, more locations. Wherever you are, we are there. UMass Memorial Healthcare, 855 UMass MD.
For the latest in health trends and news, be sure to watch our Health Watch segments Wednesday nights on Worcester News Tonight at 10 p.m. and 11. Also, prior segments can be viewed on our website, www.chartertv3.com/health. Thank you for watching this edition of Health Watch In-Depth presented by UMass Memorial Healthcare. I'm Andy Madison. Have a good night.